Emeritus member, professor, ASC, American Society of Clinical Oncology. We have to see that. That's it all.
Greetings from Digital IMA. I'm Dr. K.K. Agarwal, its Honorary Secretary General. Welcome to our show, weekly webcast, and every Thursday. And me, my colleague, Dr. V.K. Munga, who is the Dean of IMA CGP for this year. We interact with an expert. Today is a Cancer Day, so we are talking about cancer, what a GP must know. And with me, I have Professor P.K. Julka, who is also a Padma Shri awardee and who is an honorary member of American Society of Clinical Oncology and a professor of oncology and onco-radiation at Delhi-based All India Institute of Medical Sciences. In the next 1 hour, what we are going to do is we are going to come back and end with 9 or 10 points which every doctor must know about cancer. To start with, what are the common cancers in India which every GP must know?
Yes, now we have to see that in males, as per our cancer registry figures this year means published in 2015, but they are of 2010, because we take a long time to publish. Unless and until it is published, we cannot say it. So the commonest cancer in males is lung cancer and head and neck cancer. And then comes the next cancers in females. Breast cancer is the commonest, and next is cervix, uterine cervix, and next comes gallbladder and uterus, body uterus.
So what you are talk about is there has been now a reversal. That previously we used to say in urban area lung, rural area head and neck,
Yeah.
but now there is a
reversal. What is happening is in all the metropolitan cities, breast cancer is number one in females. In rural areas, still cervical cancer is to the tune, like about breast.
About breast
About
cancer,
breast
and then
cancer.
gallbladder. Third is gallbladder. Gallbladder in women.
Women.
And uterus
Ovary.
in women.
Yeah.
Ovary.
This is Delhi cancer population based.
Uterus and ovary will come
later.
Yeah.
Yeah.
And so in male it is lung cancer.
Lung cancer, head and neck cancer, mouth cancer, oral,
I know, but then,
larynx.
and both of them are
And
related.
then secondly, what is more important is prostate cancer has come up.
Bladder and prostate.
Prostate only.
So
Latter is still
after lung, head and neck, and then prostate. That's what.
According to Delhi Cancer Registry.
This is Delhi Cancer Registry.
Yes. Delhi Cancer Registry is a population-based cancer registry, not only limited to Delhi, but it is NCR, total NCR. It includes 167 private centers and 250 government hospitals. In all the NCR. And then about 17,000 cases are being screened every year.
But why do you take 5 years to tabulate the data?
No, because the data goes to Bangalore. National Cancer Registry program is in Bangalore. And Dr. Nand Kumar is the chief.
It takes time not to reach
It takes time to analyze the data, and they have to send to IARC.
Okay, so we'll come back. So therefore, let's concentrate on cancer of the lung, head and neck, prostate, and then let's concentrate on breast, cervix, gallbladder, uterus, and ovary. Let's concentrate on that. So therefore, in a GP,
yes,
at what age and how should he suspect that patient may be having cancer?
Now, GP should know if any breast lump comes to a GP. GP should not say that only FNAC kar do and then it is off. FNAC is not the only way to diagnose. Mammogram, yes, of course, but that also depends on the age. Suppose you are diagnosing a case of breast lump at the age of 28, then you won't go in for mammogram because the breast density is high. in younger age group.
Yeah.
If the density is high, MRI is a better option than your mammograms. Above the age of 40, those who have family history of breast cancer, then you should go in for your mammograms. And
Even without a
after-
lump, you mean, I mean?
No, without a lump, if family history is positive, then you have to go in with, even without a lump.
Correct.
Clinically, first palpate it,
Mhm.
and then if on palpation you find that there is a small doubtful lump, go in for a mammogram. Mammogram is not a complete, investigation.
That's right.
Then mammogram guided or ultrasound guided, go in for a FNAC or biopsy.
Should we go for FNAC at all or?
FNAC is important in the sense if you are not suspecting anything, it's a benign fibroadenoma, then you can go in for FNAC. But if FNAC is negative, then biopsy must be done.
Negative means what?
Negative means FNAC is normal, but it doesn't show malignancy.
No, if it shows adenoma,
Adenoma, then it's alright. But if it shows that you are suspecting malignancy, but it shows no malignancy, and there are no microcalcification in the mammogram picture is completely round, opaque shadow.
okay.
And there
So,
is-
for the listeners, we are at IMA website. You can directly go to IMA website. You can also go to eMedinexus.com, and if you go to eMedinexus.com, you will get a Facebook-like page, and there you can directly interact with us. You can post your questions, you can interact with us without any problems. So remember eMedinexus.com, or you can go to our website and ask questions. Now again, you can also call up 98101-18256 if you want to SMS your questions. You can also SMS your questions to us. Now, so a GP, if somebody comes with a lump, fine,
Yes,
but before that,
yes,
in which cases he should tell the women
right, beforehand.
Yes.
Yes. Now, it is very important for a person, not a patient. A person who comes to you with strong family history of breast cancer. Like mother having breast cancer, grandmother having breast cancer, or Masi having breast cancer, mother's sister, or from father's side also. Anybody having breast cancer, you should always tell them to do breast self-examination starting from the age of 30.
Okay.
And then clinical examination again after the age of 35, and mammogram after 40. So that should be the scenario. So if mammogram is normal, then it can be done after 2 years or 3 years. Because every year mammogram, recently there was a controversy that mammogram overdiagnosis is done and more biopsies are being carried out. So that should not be there. Clinical palpation by a good surgeon or by a good physician who is accustomed to this can pick up many lumps. And beside the lump, there may be retraction of the nipple. Or there may be axillary nodes. There may be supraclavicular nodes. So all these you should look for.
For discharge-
And then
discharge
you should inspect and palpate both the breast, not one. So both breast mammogram should be done. Bilateral ultrasound should be done if you are suspecting it, and then go in for biennial or after 3 years.
so breast examination at age 30.
Self-examination at 30.
No, why self? What I'm trying to talk is, why shouldn't every GP
Yeah,
have a clinic,
right,
say once in a week, with a
definitely.
male or female doctor?
Yeah.
It's only a breast examination week.
Yes.
Every
that-
girl comes, get the breast examination, tappa, negative.
Negative.
Well, say self-examination, whatever you do, they will
They will
the
miss-
female will always be
Miss
feeling.
it, miss it.
She will go to say no. It's
Because
okay.
India, what we have found, that especially in rural areas, they don't do self-examination.
Nobody
Number
knows.
one, they don't know how to do it.
Yeah.
Number two, secondly, GP should always tell how to conduct a breast self-examination. This also he should teach the ladies GP should teach the ladies how to conduct, because they don't know. Now left breast is there.
No,
You
do
will
we
use
have
your right hand.
Do we have a
and-
standard video?
Yeah, we have a video.
Exactly
Yeah,
teaching.
we will give you the video which teaches how to conduct a self-defense.
I'm coming back. I'm coming back. Is why can't we come out as a policy
Yes.
that we say Thursday or a Friday or a Tuesday is a breast examination day.
Absolutely.
All women should go to the doctor every 3 months on that particular day to the
Yes.
doctor and get it examined.
Yes,
Otherwise, you're going to miss.
absolutely. And we should stress to the GPs also, the early detection is the hallmark to cure.
Yeah.
Because early detection means cure plus less of your money is saved. Because
Correct.
you do only lumpectomy, you do only remove the
initial
lump,
stages.
give radiation, finish it off, no chemo required. No, if hormone positive, only tablets are required. So you should, one should say like this. I think this is a very good idea.
Saves life and
That
money
you
both.
should say one day a week, say Wednesday, every Wednesday breast clinic. So you should go in for breast, you teach them breast self-examination.
So I'm going different. Teaching is fine.
Right.
Teaching is fine. I'm only going to say is
And then do yourself also.
every 3 months, 4 weeks. See, a woman is supposed to go for you send your car for a servicing.
Yeah,
You don't do a self-servicing.
yes.
So
Yes.
you take your body
that
every
is
3
fine.
months, go to the doctor and say, examine me and also check my breast.
Yeah.
What's the...
But that
And
should be
this-
the ideal, I suppose.
That should be
See,
the
what
idea.
happens is when you talk
But
about...
this doesn't happen. Problem is
But
shortage of
I
GPs.
personally feel is, no,
Shortage
there is
of
no shortage of
GPs.
GP. I personally feel is that self-breast examination has been a failure. It has not picked up the way it should have
Actually,
been.
because nobody knows how to do
Nobody
it.
teaches, nobody knows.
teaches, nobody
And then
teaches.
if a GP...
And we talk of it in television and radio, and then it is finished.
It's all.
It is finished. And I think Dr. Agarwal is absolutely right. It should be, we'll send the video also, but still, if physical examination is done by a doctor, GP, any GP, it is much better.
Next is cervix. What a GP should do? as
Now,
far as-
cervix, important thing is pap smear.
At what
Simple.
age?
Simple pap smear at the age of 40, if you do pap smear, and those who are sexually promiscuous, in those cases, you should do it early.
See, when you talk about 30 and 40, there is a confusion.
Because, no,
No,
the
no,
problem
no,
is,
no, no,
I'll
no,
tell you.
no, no, no.
Because,
See, for a
Want to make a
GP,
formula.
there has to be a simple cutoff.
yeah,
For all cancers, you can't say breast 30 and cervix 40. Come out with 35 or 30 or 40. If
No.
you want to, why can't
these
sir-
are the standard
My-
guidelines.
See, standard guidelines, what happens is they confuse.
Uh-huh.
Unless you have a number. Standard guidelines are fine. Suppose,
Because
what's the
suppose-
harm in examining cervix at 30? If you talk about breast at 30, then cervix also, you say age group is only one. At the age of 30, look for cancer. If you
Absolutely,
say,
you
if you
can
say,
pap smear at 30 also.
why not?
That should be better.
That would be better.
Instead of 40,
Yeah, instead
why
of
can't there
40,
be a consensus?
Pap smear at 30, then you do it after 5 years. And pap
Okay.
smear. Otherwise, after 40, if you are doing, ideally
No, again,
in
again,
US.
I want-
No, no,
I still
just-
want a formula. My formula is-
I'll tell you the formula. Just 1 minute. In the West, what they are doing, every year pap smear is being done.
Every year.
Every year after the age of 40. Now,
Even if
in
there is
our
no
country,
complaint, no history,
absolutely,
nothing.
absolutely. In our country, because of lack of resources or lack of knowledge, people don't go for. I'll ask you ask the GPs, how many of their wives or how many doctors themselves get their pap smear done.
Even after 5
Even
years.
after 5 years. I'm telling you, it would be hardly 30 to 40%. They get it done. And now we have HPV DNA testing also, which should be done once in 5 years. Right? For sexually promiscuous persons, because you have to take the history
No, you're talking about HPV DNA test
every 5 years.
every 5 years after the age of?
After the age of 40.
After the age of 40.
Yes.
So
And
how much it costs?
HPV DNA in government hospital, it is nothing,
Hmm.
about 200 rupees.
Hmm.
But private is,
How much?
the private is about 5,000 rupees,
Hmm?
5,000 rupees. I think we can always do like this, that through IMA, why not we do like this, reduce the charges of these basic examinations.
Tell us, give us a program, give us a program. Tell us
I
if-
think we can give you a program for basic cancers, like cancer of the breast, cancer of the mammograms. Now mammograms, one of the private practitioners is doing very cheap, just for social service. So I won't name the person.
No, why not? Name it. I mean, if you don't name, then how will people take advantage of him?
No, because if I name, it won't be, because Colonel Panta, he
So
is
how much is charges?
1,000 rupees.
1,000 rupees. There is in Lajpat Nagar, just behind the Mulchan Hospital, there is a center who are doing for 600 rupees.
600
Yes,
rupees.
they're doing 600 rupees. That's the charitable.
What I want, the IMA should make a guideline that for 500 rupees mammogram will be done in such and such place. This is associated with IMA. We are also
Absolutely.
inclined for
Promote,
social
yeah.
promotion. Then more people will come for mammogram. Similarly for pap smear, you go in for 50 rupees, 100 rupees, because the charges for pap smear is nothing. You have to take a fluid. The only charge is seeing the cytology by a pathologist. You need a pathologist, and many pathologists will come forward for this social work. So I think that you can make a guideline for IMA.
So for women, we have at 30 years of age, we go for a regular 3-monthly breast examination.
Examination.
For cervix, at the age of 30, we go for a pap
Pap
smear,
smear.
and then regularly as a doctor decides.
Yes.
And what about for gallbladder?
Gallbladder, there is no such, preliminary.
Yeah.
Gallbladder, they can do clinical examination of the abdomen and do ultrasound.
Ultrasound what?
Ultrasound of abdomen.
When?
They can do after the age of 40.
Again 30.
30 we can.
You
make
advocate it as a routine or if you
Ultrasound
comes with
once-
complaints.
Complaints. A person generally would come.
What about
vague-
uterus and ovary?
Vague.
Again?
This.
So,
Yes.
so I can come out with that at age 30,
30, one
you
should
do a
go
pap
for
smear,
pap smear and
you
ultrasound.
do a
abdomen.
breast,
Uh,
and then you do ultrasound for GB,
Yes.
and then ovary and
Yeah.
uterus.
Yes. So that means ultrasound of abdomen and pelvis. You write like this.
Correct.
Ultrasound of abdomen
That
and
will include
pelvis.
everything, yeah.
That will include breast,
Whole abdomen and
clinical examination, and if you find a lump or this,
And then-
at the age of 30, you don't go in for mammogram. You go in for ultrasound.
At
Or at the age of
Or
30.
MRI.
if lump,
If lump positive,
go for
ultrasound.
MRI or ultrasound.
Or first ultrasound, then MRI. Because MRI is expensive than ultrasound. Ultrasound is very cheap,
Yeah.
MRI is very expensive. So I think we should make these guidelines for IMA and follow it up. We can make one center where people can go and say, this is IMA center, and we can get it very cheap. We can do that. I think that would help.
And
serve
after the age of 30, every 3 years,
one should go in.
one
for-
should go minimum, maximum after every 3 years, because that's every 3 months breast examination, every 3 years
3
examination.
years.
Number 3 will remain.
Yes.
Okay. Now males.
Now males, the problem is that there is no such examination for males, except for, you can go in for ultrasound abdomen to see for, because colorectal cancer also is picking up. And then chest x-ray, once, chest x-ray we cannot do, that's not the right method, because you are giving radiation.
Sure.
In US, in Western countries, what they are doing, low dose CT scan
Okay.
in heavy smokers.
Mhm.
So people who are smokers, heavy smokers,
Hmm.
like 10 pack years.
Hmm.
10 pack years means 10 cigarettes a day for 10 years. Those who are smoking, for them, go in for chest x-ray.
Low dose spiral CT as a screening,
Yes,
then if
screening in the
negative.
West. If negative, then you watch
From many years.
every 2 years. Every 2 years.
So, otherwise, in males, we don't have the.
We don't have any specific, because low dose CT scan, we are not doing it because we don't have the facilities.
So we don't have any low dose CT scanner in India.
No, we have low dose CT scanner, but we are not doing it routinely.
Okay, then in male, what cancer?
In male, that is what I am saying. 10 pack years, for 10 years, 10 cigarettes per day. Those who are smoking, go in for chest X-ray. If chest X-ray shows a doubtful shadow, go in for a CT scan, proper CT.
Okay, apart from that, prostate, we don't have any screening in India.
Prostate, actually, PSA has proven to be not very effective.
Mm.
So, but once you get a blood test done,
Mm.
then you can get PSA done.
At what age?
After the age of 40. Because before 40, there's no point getting PSA done. And even if PSA is high, and one should see that clinical examination has not been done beforehand.
Mm.
You do a PR examination and do PSA, it will come as high.
And what about oral cavity?
Oral cavity is that you examine the oral cavity after the age of 30 in tobacco chewers. Tobacco chews after the age of 30, otherwise after the age of 40. So for males, we fix at 40. Only 30 would be for those who are either smoking or taking pan masala and gutta and tobacco products, smokeless tobacco.
So somewhere we have to say you say breast examination at 30. Should I shift everything to 40? All examination at 40?
No, 30 is a must.
Breast
Actually, we always say 30.
So what is at 30 and what is at 40? Let's revise.
At 30 for females, we have done 30, and for males, we have done 40.
Female 30, male 40.
That would be ideal. And male earlier, if he is taking tobacco chewing for the last 10 years or 15 years, then we have to be very cautious.
And then special screening method for tobacco.
Yeah.
Tobacco.
Tobacco,
Can-
smokeless and smoking. Both.
Yes. Back years.
Smokeless and smoking, both.
I remember on one of those first July programs, Doctors' Day programs in East Delhi,
Yes,
IMA,
yes,
we invited all the doctors
yes,
to come for a screening in a big hospital in East Delhi.
yes.
And I tell you, not even 0.1% of the total doctors turned up.
No,
Doctors
this
are
is-
also.
Doctors are also, this is what I am saying. If doctors, I was asking you that how many doctors have done their pap smear? You
No,
won't find
Only
any.
around 20 pap
No,
smears
no,
and maybe around
we
10.
we are seeing doctors coming with breast lump of 10 centimeter. Can you beat it? I said, what were you doing? She says, I was going for homeopathy, Ayurvedic. So I think we should always tell GPs knowledge about homeopathy and Ayurvedic. That I'm not denigrating, I'm not saying that is bad, because there are no clinical trials.
So
with
if I want to
homeopathy.
prevent all the cancers,
Yes.
if I want to prevent all the cancers, what 4 or 5 things I must do?
Number one.
I'm not talking about a particular cancer.
No, no.
So
All cancers.
So no
number
tobacco?
one, no tobacco. No alcohol.
Alcohol can't be zero because
No, moderation. Moderation.
So-
Yes.
Alcohol in moderation.
so alcohol
Not more than 1 pack a day.
moderation 30 ml.
Yes.
Then
Not more than
hmm,
one.
Weight control.
Weight control, obesity,
so obesity,
weight control.
hmm,
Diet rich in
fruits and vegetables.
Fruits and vegetables.
So fruits,
and vegetables,
vegetables and fiber.
fiber, diet.
Diet.
Then exercise.
How will exercise prevent cancer?
Yes, exercise prevents cancer. Sedentary habits leads to obesity.
No, I know, but that's through obesity.
No, but otherwise also exercise it stimulates the system against cancer cells also.
Anything else?
Then we can say promiscuous habits.
Hmm.
Then another is if we can tell oral sex. Because now 30%, 20 to 30% of HPV related head and neck cancers are there. So HPV
30,
20 to 30%.
30%.
HPV related or head and neck cancers.
HPV related.
Head and neck cancers which are related to oral sex.
Could you talk about immunization also in prevention of cancer?
Prevention, yes, we'll come to immunization.
Okay.
First we'll talk about general.
Okay.
So when you talk about oral sex, you're talking about it without
HPV
condom.
related, yes.
Oral sex without condom, unprotected oral sex is linked with HPV infection, which is related to
Head and neck
head
cancer.
and neck cancer.
In West it is 70%. And that is why they are getting vaccination against HPV in males and females both. Because their males to males is also there and males to female is also.
Okay, when you talk about, you only raise the point of vaccination. Let's talk about anti-cancer vaccines.
Anti-cancer vaccine. Now, most important is your HPV vaccine. HPV vaccine, which unfortunately, after the death of one person, ministry is dwindling, ICMR and ministry, because whether it was related to HPV vaccine or not, we don't know. But they said they are not promoting it.
No, but let's talk about the private sector. Let's forget about the government. What is the protocol?
Protocol is 0, 1 and 6. Now that is 3 vaccines.
At any age or?
No, it should be before the first sexual encounter. So we say age 9 to 18.
Age 9 to 18.
Before the first sexual encounter. If sexual encounter has been done, then no use to getting. 60-year-old female comes, you give me the vaccine. What is the use? For so long she has been infected.
Yeah.
So we don't.
But how do we know? Suppose a married girl comes.
Yeah.
And
No, after marriage we should not give.
No. Suppose why can't we do the testing and see whether the HPV is there or not?
The testing can be done.
And if it is not there, why can't
No. Then
multiple sexual partners?
Multiple sexual partners, then that is very, because for them before they indulge in sex, then you should.
It is not effective or it is not indicated?
It is not indicated.
No. I'm talking about a girl comes. Say she is married.
How
Husband
many
dies.
years?
She's 28. Husband dies. Now she's getting remarried. New person comes into her life.
If HPV is negative.
If HPV is negative.
Then she can get it.
So therefore, HPV, no, in a person who is already sexually active, no vaccine without doing the HPV testing.
It has.
Will that be?
Ideally, it should not be. It is not indicated in a sexually, active person. But if a situation like this.
No, oral sex.
Oral sex, yes. Oral sex, those who are doing it before.
But, see, most of the people who are MSM or oral sex, they have multiple partners.
Yes. They should be all that is why they
Therefore,
are
I'm saying that.
vaccinating.
So therefore, vaccination has to. See, even if a person is
Actually,
married.
then you have to vaccinate the entire, the younger generation school. That is not possible, humanly possible, because we should see those things which are possible. Because if we go to schools and educate them about sexual promiscuity, then it is ideal. But boys and girls, they adapt Western lifestyle, so you can't force them. But as he said, those who are going in for oral sex, you should vaccinate them before that. In West, they are doing vaccination for all boys and girls.
And then there are 2 types of vaccines, HPV.
2 types of vaccine, Gardasil and no, that is immaterial. Whichever vaccine is available, but they are a little expensive. We can always tell the company to supply. If IMA decides to vaccinate most of the people, then we can always tell them to supply at a reasonable cost.
And there is no other vaccine for any other cancer except for.
Not proven vaccine for vaccines are.
Hepatitis B.
That's for liver cancer.
Hepatitis B is already included.
Yes.
Hepatitis B is already included. Only vaccine available for cancer, prevention of cancer, You are right, hepatitis B is also for prevention of cancer. The hepatitis B should be given to all, आजकल तो it is in the
Every
immunization
child gets
program.
it.
It is in the immunization program also.
Mhm.
But HPV vaccine is important for cancer, prevention of cancer cervix. Now, I must tell you that cancer cervix is not common in our metropolitan cities.
Yes.
Somehow, because I think people have become educated and they are using
No, which are the cancers which are
Yes.
related to virus?
Virus is
Viral
number one.
related cancer.
Viral related cancer, number one, cancer of the cervix.
Hmm.
Number two, HPV related head and neck cancers. This is
Hmm.
also HPV related, this one.
Hmm.
Then HIV related cancers.
Hmm.
HIV, human
Yes.
immunodeficiency virus, that can lead to lymphomas, that
Mm.
can lead to
Sure.
primary CNS
Mm.
lymphoma, that can lead to
And then-
Hodgkin's, non-Hodgkin's, cancer of the cervix.
Lung cancer
of
is
the-
related to virus.
Lung
No.
cancer is not related to virus.
Hmm.
That is mainly smoking or some genetic defect,
Hmm.
like EGFR
So
mutation.
we don't have any other viral related cancers.
HIV related and Epstein-Barr virus.
Hmm.
EBV, that is nasopharynx. That is mostly in northeastern state. Delhi it is less common. Because Delhi may only people come with nasopharyngeal carcinoma from northeast. Northeast say they come, and because Epstein-Barr virus is positive, that is why if EBV DNA is positive, we do DNA for that also. Then we give chemo also with radiation. Otherwise only radiation.
So let's revise till now is that
Achha, secondly, if I must tell you that GPs should know that HPV related cancers have better prognosis. And for them, less treatment is required. Because HPV responds to radiation immediately, it melts. So that also GPs should know. Not that I am promoting that. you
That's
should
okay,
get
that's right,
HPV, no? So that they should be educated about that.
now my next thing comes is that nowadays everybody says cancer treatment is becoming very costly. And
That
because
is
of the all your
New molecules.
new molecules,
New
how important are they?
Actually, I'll take example of lung cancer,
Hmm.
which is commonest.
Hmm.
Lung cancer people mostly, earlier, I'm talking of 70s and 80s. 90% of the people came in stage 4,
Hmm.
right?
Yes.
Now 60% are coming in stage 4, 50 to 60,
Still majority.
still majority
Hmm.
coming in stage 4. Why? Because number one, again role of GPs. They are being,
Diagnosis, late diagnosis.
they are being treated for tuberculosis for 6 months.
Okay.
And GPs continue treating them for tuberculosis. This has to be told to GPs. ये very important point, lung cancer का. We are getting, we asked them whether he was treating for tuberculosis. He said, no, tuberculosis is commonest. Let us first give tuberculosis and then we'll see. Then he does a biopsy and then.
No, I say if a lung cancer today is diagnosed,
Yes.
suppose.
Early stages,
Hmm.
surgery or radiotherapy.
Hmm.
Radiotherapy is a special form of radiotherapy that is called SBRT. SBRT means stereotactic body radiotherapy, localized,
Mm.
high dose radiotherapy. It burns the tumor, but it should be stage 1.
Hmm.
Stage 1
Only
means
stage one.
no mediastinal nodes, only stage 1. If we cross stage 1, stage 2, stage 3, then concurrent chemoradiation is the answer. If surgery not possible. Sometimes surgery is possible even in advanced cases, like stage 2 and
No, again, I'm only going. My emphasis is on for poor people. What do they do?
surgery would be the first option for early cases.
Hmm.
And
No, I'm talking about all
What-
these newer drugs
what we are doing
which
for
are
stage 4, now I am coming
DNA
to that.
blockers and other drugs which
Yes.
have come.
Now what we do, EGFR mutation and ALK testing, ALK.
A.
ALK.
Hmm.
These two genes are being tested.
Second gene is?
EGFR. EGFR mutation and ALK mutation.
Hmm.
These two. If EGFR is positive, then we give oral tablets. Jeftinib or Afretinib or whichever.
Mm.
If ALK is positive, we give Crizotinib, which is another tablet.
Mm.
Now, this is also very important. What IMA can do or what GPs can do, you should educate them. And these are big companies like Pfizer and all these companies, what they are doing.
What I want is, I want these
Just
4 cancers protocols,
Hmm.
a flow chart,
Yeah.
which is there on the IMA website.
Yes, that will give
4
you.
or 5 cancers. We don't want 10 cancers.
No,
This,
we will do
5,
for,
6 cancers.
2 important male cancers, 2 important female cancers.
That's all. This is there on our website. This is how you
Website.
approach.
Yes,
Do
this
this
is how
test.
I approach.
This test is available at this
Ah.
lab, and the cheapest test available at this lab.
Yes.
This is a drug, the
But
cheapest drug.
can we have, now, for example, what we do in AIMS, we tell, suppose Pfizer people, they have a drug, one drug for this. They will do testing free from any of
We'll
these
put it
drugs.
on. We'll put it on our
Conquest,
guidelines.
Conquest and
No.
Diagnostics.
What I'm trying to
You
say
can
is,
tell our
Nee,
branches
why
to do
not,
it,
why
yeah.
not IMA does collaboration with these labs? Or even you can tell Dr. Lal's lab.
that's what I'm
He
saying.
can be one of
What
the
I mean to say,
partners with.
I will sit with you. We are going to come back with 4 or 5 or 6 common cancers with total protocol and aimed at people who are middle class or lower middle class.
Yes.
Where we will mention these are the
Those are no
these are the
realistic.
drugs which are the cheapest.
Uh,
These are the protocol. These are the labs which provide the most economy. So that those
Or you
people
can have arrangement with these labs and
That
tell
is what
them
I'm
of the
saying.
state branches
Yes.
that they can call
They
upon
can
them
call
so
upon.
that they can hold a
For
free
example,
camp or-
I'm
yeah.
just giving you example
Yes.
of Dr. Lal's path lab. We can tell Dr. Arvind, you have to do test at this, suppose 100 rupees, 200 rupees. We will send you bulk of cases. All IMA cases who are, near your branches.
They can do it all
they
in
can do
state
all,
capitals,
because
yes.
if the volume is more, it
Mhm.
won't be very expensive for him. Right?
absolutely. But
So I think
because
we
today
can help the poor people.
all the GPs are afraid of cancers because they say that
Expensive.
the treatment is very expensive because the treatment now they talk for 40 lakhs, 50 lakhs, 60 lakhs.
Actually, what we are doing, Herceptin also, monoclonal antibodies against HER2 breast cancer, that has to be given because this is a must, otherwise brain mets come.
Mm.
Poor patients, what do? We send it to Prime Minister Relief Fund.
Mm.
And I was going to PM office, in Mr. Modi's office, to sanction the money, 3 lakh of rupees to these poor patients. There is another scheme from Ministry of Health, that is RAN scheme,
RA?
RAN.
Mm.
So that is for poor patients, they give Rashtriya Arogya Nidhi.
Mm.
This is called
Okay.
Rashtriya Arogya Nidhi scheme. They also give for poor patients. So
But then how many
our
of
poor,
patients reach?
what
No.
I do.
This has to be done by the branches. No? Local
Ah,
branches has to
yeah,
move the
local-
application.
Yes.
That's right.
If local,
The GP should talk to the
what
branch
I'm
and
saying,
then-
if
yeah.
local branches can approach health ministry
Mm.
and, the director CGHS, if you approach him,
Mm.
he's giving for CGHS,
Mm.
for IMA also, if you can call him in one of the IMA functions
Mm.
and then request him, that for our poor patient, middle class patient or lower middle class.
So therefore, Dr.
everybody
Durga,
is
what
not,
I need is-
everybody is not BPL. I must tell you, because BPL patients get free treatment in our hospital also.
Mm.
And I think in others also they must be.
In many hospitals.
Many hospital BPL is free.
Ah.
But there is a class just above BPL who cannot afford anything.
Most hard pressed.
Most hard pressed.
Actual
So,
BPL, these are actual BPL people because they don't have
They don't have BPL card.
No, they don't have the know-how how to get a BPL
How to
card.
get a BPL card.
Yes,
So
yes.
those
They
are
are the real BPL people.
and then come the middle class. So these are the
No,
oppressed
what
class.
I
And these class should be helped.
what I need is this 6 cancers.
The 4 cancers.
You said, see, I will breast,
to
cervix,
male to-
breast, cervix, gallbladder, and uterine.
Uterine.
And there I would take it cancer of the head and neck, lung, and prostate.
Prostate, yes.
For this 7 cancers, I need a standard protocol.
Right.
I will sit with you.
Right.
Then I will write down in that protocol where to go, including the costing, including the medicine costing,
Okay.
including the lowest medical costing. And then I will write down, even if you can't afford that, then these are the options still available. These are the people who can help you out.
But we have to talk to some of the labs from first.
People will come automatically. People will come automatically.
Or we can talk to Dr.
That we will do that. What I'm trying to say is, see, even if I do that, that will be a service which I'm providing to the
That will
society.
be, yes.
As on
That-
today, there is total confusion. People who are rich, let them spend money.
Uh,
But a lower middle class must
Yes.
know.
And CGHS people, I remind you, they get all from CGHS, worth lakhs of rupees. Now her
Okay,
septin
there is a facility to
treatment,
that,
her
yeah.
septin treatment, 17 injections. Earlier it was 1 lakh each. Now it is 50,000 each. So you can
It's
see
a big sum even now.
10 lakhs.
Mhm.
So 10 lakh treatment of HER2 positive breast cancer, who can afford? Nobody can afford, except when you are getting it. Recently one police IPS officer came, he is getting it from CGHS. So he says no problem for them. I said, for you it's no problem, but what about others? We feel so bad if we are not able to provide the right treatment for the right person. We are talking of personalized medicine.
What about monoclonal
Yeah.
antibodies? Monoclonal.
This is monoclonal antibody.
Apart from that,
Herceptin.
Herceptin.
Apart from Herceptin, rituximab is there for lymphoma.
Hmm.
That also we are not able to, again, we go to the end of this PM relief fund. We have these two sources. And then we have another source in our aims, that is Gopal Foundation.
Hmm.
Gopal.
Foundation.
Hmm.
I think these are the same persons who make Zarda and but they are giving free temozolomide, that is again a costly drug for brain tumor patients. That is a must. Glioblastoma and grade 3. Grade 3 and grade 4. Grade 4 is glioblastoma, grade 3 is anaplastic, astrocytoma. So for grade 3 and grade 4 you need temozolomide with RT. And temozolomide treatment is again 5 to 6 lakhs with generics. So how to go about that you have to decide which company you will follow. Because there are many companies like Cipla, Natco, all these companies, they are ready to help.
Mhm.
Because I have talked to various companies, because we get free for most of the patients. I see to it that every patient, down to earth, poorest of the poor, gets the right treatment. Whether I have to go to PM relief fund or whether I have to go to that. Our patients are getting all the treatment. And I make permutation combinations, or from Gopal Foundation. So these are the people who are plus then Cancer Aid Foundation. That is also
Cancer?
Cancer Aid.
Mhm.
That is also helping us.
If you are done with the treatment part, I think about tobacco control, would you like to comment on eating tobacco
Why can't we
smoking?
do
Yes.
in one of the IMA meetings, why don't you ask how many doctors are smoking?
Quite a few, I believe.
No, what I am saying, you let us start from the doctors. Because Gandhanagi, it starts from the, charity begins at home. So always start, in one of the IMA meeting conferences, national conference,
Mhm.
you must say ki how many doctors are smoking, tell us frankly, and raise hands.
What is your guess?
My guess
8
is.
to 10%?
No.
More than that?
30 to 40%. Now what I am saying, we should start, the charity at home, begins at home. We should tell the doctors to tell the patients who are coming to them for routine checkup or routine examination that I am not smoking, please you also stop smoking. On every visit, he should say stop smoking, because public memory is short.
That is what I.
Public memory is short.
Nobody.
On every TV program on total health, you must have seen some of the programs. Last Sunday I was there. No tobacco, no smoking, no gutka, no pan masala. So every program
But
I
does it
attend,
help? Is it helping?
it is helping.
Okay.
Yeah,
That's it.
smoking is coming, because we tell the relatives of the patient also. Okay, now you see, and a person was smoking through the tracheostomy tube. He said, even our former IMA chief was, I told him. See, what I am saying, addiction is there. We have a national de-addiction center at Ghaziabad, AIMS, at Ghaziabad. This is very important for GPs to know, that they can send any patient of addiction, any addiction.
Any addiction.
Any addiction. So they can alcohol, tobacco to Ghaziabad National De-Addiction Center, NDTC at Ghaziabad. This is AIMS. Right? This is also GPs should know. So that can help.
How many people they can cater to?
It's a big compound, very big compound. I think you should go and see once.
Where in Ghaziabad?
Ghaziabad beginning में ही है. You can ask for national de-addiction centers.
And Dr. Another thing, I mean, you were on Times of India today talking about pollution and its effect on
Yes,
cancer.
because no, what we were saying, that actually the message should go clear, that pollution causes cancer. Randomized trials have not proven this.
Yeah.
Right? Now, non-smokers
More and
having
more
lung
smoke, yeah.
cancer, they are coming in more numbers. There must be a genetic defect, or there must be some other pollution could be playing a role. Because if they are not smoking, they may be passive smokers, or they may be burning chullas at home, or they may be burning agarbattis at home. Any dhua, smoke, which is coming
But chula burning is, I mean, definitely lesser than it was
lesser
20
than
years back.
but still it is there.
But-
Northeast, why the cancer is common? 234 is the incidence in Northeast. Why? Because people are living in this room and they are making chapatis there, they're making vegetables there in the same room and inhaling the same smoke, and they are chewing tobacco and smoking also.
Couple of things quickly now. Cancer in children.
Cancer in children, one should be very cautious, because cancer in children could be, brain tumors are very common in children.
Linked to
It's a genetic. It's not hereditary.
cancers in the elderly.
Cancers in the elderly could be, I told you, 40% tobacco related, alcohol related, 20% is infection related, 20% is lifestyle related, and less than 10% is your hereditary or family related.
Okay, we have not talked about skin cancer. How common it is in
Melanomas are less in
Less.
India, because it occurs in fair-skinned individuals.
Okay.
Though we have fair-skinned individuals.
What about basal cell carcinoma?
Yes, that is again less common. And exposed to sun for a long time. Here.
What about
people-
second cancers?
People don't go to beach and.
Second cancers.
Huh?
Second cancers.
Second cancers are there, because a person having a cancer has immunodeficiency. So he is more prone for getting second cancer. So it is in 20 to 30% of the cases they get second cancer.
30 to 40%.
20 to 30%. 20 to 30%.
This is a very high number.
Yeah, especially head and neck cancers, because the carcinogen is same, and entire mucosa is at rest. So if you are having buccal mucosa cancer, you can have tongue cancer, you can have the cancer.
No, I've seen two people with breast cancer going into AML.
Yeah, people can go into AML, or people can go into ovarian cancer. So that is the second malignancy. So it could be radiation-induced second malignancy also, RISM. So those who have, there was a study published, Hodgkin's disease. We used to give radiation to the chest, and then people used to come with.
What do you mean by
breast
cancer is curable?
Cancer is curable means cancer is curable if detected early.
No, what is the definition of cure?
Cure means that he is disease free for at least 5 years. 5 years survival should be 100%. That is what we want. If he is cured for 5 years, he is cured.
That means
Because
after that he is cured.
After that he is cured. Except for certain breast cancers, which I always say ER positive, hormone receptor positive, which can recur after 20 years or 15 years. So that is why ER positive breast cancers, hormone receptor positive, should be followed up for lifelong. As such, all cancers should be followed up for lifelong, not 5 years. But 5 years survival means survival for us.
That means if 5 years there is no recurrence,
Then
it is cured.
It is cured, more or less.
Taken as cure.
Taken as cure. Taken as But we would like them to be on follow-up throughout life.
What about our great cricketer's cancer? It was cured.
Yeah, it is cured. It is now more than.
What
3-4
type was
years.
it?
Huh?
What
It
type
was
of
a
cancer?
germinoma. Germinoma. That is a curable cancer.
So this is cured.
Yes.
So that's
Actually, like seminoma in testes,
Hmm.
curable. They generally come in stage 1.
Mhm.
They don't come in stage 2 or 3 because
Yeah.
testis swelling is there. They come.
Mhm.
Very few keep on waiting and paralytic nodes come. So we remove the testes and find the tumor is localized to testes and then give radiation or give carboplatin 1 dose. They are cured.
Why some cancers behave very rapidly progressive?
They are poorly differentiated cancer. Type of cancer, subtype. Their subtype is anaplastic type. They are poorly differentiated. Their cells multiply rapidly. So that is why they spread like wildfire, just like glioblastoma. Glioblastoma is a cancer grade 4 of brain tumor. And that's, median survival is 14 to 16 months, despite the treatment. That is surgery, radiation.
Lung cancer I was studying
Yeah.
in US. They're doing a trial. They're taking lung cells, cancer cells,
Yeah.
and then they are irradiating them again and again. The cancer cells are being repeatedly irradiated
Yeah.
and then injected to the person, same person.
No, this is one form, but it is not, it is experimental stage.
Yes, it is. It is a trial.
Trial, this will not work, because, autologous, homologous, that is not the way. Actually, there is another way which they are doing, implanting cancer cells into mice, xenograft models.
Implanting?
And, the cancer cells into mice, that is called a xenograft model. Patient-derived xenograft, PDX. Right? PDX, after xenograft, they are testing various drugs. So, after testing these
No.
drugs.
You take the cancer cells, inject it into the mice. Then what?
The cancer grows.
Cancer grows.
Then you give various drugs which are active against that particular, suppose lung cancer. Lung cancer cells are injected. Now we know that taxanes are effective against this. We give paclitaxel injection to the mice. The cancer shrinks, or it may not shrink. Suppose it doesn't shrink, then we give another drug. So we can know which drug works in this particular cancer. The drug which works in mice will work in the same patient.
So that means
So
the cancer is transmissible
Yes,
from human to mice.
human to mice. That is called PDX model, patient-derived xenograft model. Then there is another important thing which.
Is this being done?
This not here, in the US.
Nobody is doing it in India?
In US, this is very recent.
Because this is something new, because that means you can transfer the cancer
Into mice,
into the mice.
yes.
And then
That
select the
means-
medicine.
Then select the medicine,
That means if I take a FMSC,
yes. You can inject
No.
into,
if I take an FMSC and inject it into the thigh, the second will develop.
No, no, not that. The same individual, it may not develop.
No,
Your body's immune mechanism will fight against your T cells.
no, my own cells.
Ah, no. Even if you take your own
If I take my own cancer cells
and inject into the thigh,
into thighs, then the thigh secondaries will come.
no, not necessarily. Because your immune system, which is working against that, has become weaker. But your T cells will immediately come and conquer this second site. So this is the result of immunotherapy which is coming up.
Why I'm saying this? Because there is a misperception. Everybody is afraid. FNA से नहीं कराना. Because if you touch the cancer, it will spread.
Yes,
It will spread.
yes,
That is
a misnomer.
That is a misnomer. But if your theory is correct,
Yes.
that
No,
cancer
that-
cells are transmissible from
Yes.
one place to another,
Yes.
then that may not be a myth.
No, that is a myth till today. Till today means till it is proven that it causes this spread. MD Anderson team from MD Anderson in US, they have said that in certain individuals, the cancer spreads by biopsy. But it has not been proven by any scientific trials. Till that is proven by scientific trials, we don't believe that. So you can't go on hearsay.
But you yourself are telling that if I take the cells, put it into the mice.
Mice. In mice it will grow because these mice are deficient in immunity.
Oh,
And they are T cell immunodeficient mice.
they're specific mice.
Yeah.
Not ordinary.
Not ordinary mice. Immunodeficient mice. But if you inject in your thigh, then what will happen? Your T cells will come and capture it. And this is the basis of immunotherapy. Immunotherapy, what it does. Now there are new drugs have come for immunotherapy, monoclonal antibodies,
Hmm.
so which we are using also, and they're 3 lakhs each.
What is that?
That is pembrolizumab and nivolumab.
Hmm.
These are checkpoint inhibitors.
Hmm.
What happens if, like T cells are being suppressed,
Hmm.
cytotoxic T cells. We have T cells and B cells, lymphocytes, which fight against
Hmm.
which are our army
Hmm.
Yeah.
against any infection or any cancer. Now they are being checked by certain checkpoints. These checkpoints are called programmed death receptors, PD1. And they are PDL1. There are ligands, PDL1 and PDL2. They combine with PD1 and then induce the cascade. That means they go check the T cells, and T cells cannot fight against the cancer. Right? Now what will happen if we inhibit these checkpoints by drugs called nivolumab or pembrolizumab? We are inhibiting this checkpoint. PDL1 is not able to react to PD attached to PD1. Then this cycle is broken and T cells will come and attack. And we have used this in our practice.
किसी को सवाल आएगा क्या? इसमें नहीं आ रहा. मेरे में नहीं आया.
Phone number किसका?
Is there any question? Which is?
No.
So this is the new therapy which has come.
Let's hope
Immunotherapy
for
cancer.
years to come here.
Yes.
So, and that's the end of the day. Let's all celebrate Cancer Day in the country, and we will make a summary out of it. And you will find this summary in the next couple of days in our EIMA news. We'll distribute it to the whole country. And as promised with Dr. Julka, we are going to come back with some basic flow charts, and we'll try to see that cancer treatment becomes available to the people who otherwise cannot afford. Let's thank Dr. Julka for being with us in this show, and
Thank you, sir.
Dr. Monga and me say goodbye to you. Next week we'll come back with one more issue. In the meantime, we are also preparing some update on Zika. Maybe next time 15 minutes we'll spend on Zika. And we are also developing a course on Zika. It will be a 1-hour course which may be ready in the next 2 weeks. And that course we will like every IMA member to join, read, and get prepared for Zika. IMA is of the view we don't know whether Zika how will enter in India or not, how will it behave. You remember that India has Aedes aegypti, but yellow fever could never enter India. Virus, the mosquito is there. Chikungunya came, it hasn't gone the way dengue has gone. So we have the same mosquito causing 3 different diseases with 3 different patterns. Will Zika behave like yellow virus and not enter India? Will it behave like chikungunya and become sporadic? Or will it become like dengue and cause a catastrophe? Let's watch a couple of programs. We'll update you regularly. Thank you very much.